So I have Jack, Daphne, Laurie, and Mark Logtenberg. And we've been getting some questions. So I have, the way to answer the questions is... Hello? So you pass the mic around.
You can bring the brownie up. You can bring your brownie up.
Okay, so I don't think we need to do any introductions. I think these are our four speakers for today, so you know them. I've been getting quite a few questions from the audience, so everyone will get a chance to ask more. I want to spend half an hour, 45 minutes, and then we're within schedule. So the first question is there a way of knowing how long I've had acromegaly? I was diagnosed in 2002, and my wife always said, you had it for 10 years, but there's no way to really know that. Anyone want to sort of take that one on? Yeah, the microphone should be on.
Okay. Yes. Bring in your a series of photos in 5-year increments. Particularly in our case, Shireen's really good at this. Even I've picked it up. That we can start seeing the changes.
Mm-hmm. Okay, bring photos. Anything else? Is there any other way to figure it out?
So the only way is to get a blood test, though, the IGF-1 would be, and then the MRI. That would confirm it. But the photos is great so that you can, because we look at that as well. So, and then we're going to write down all your symptoms as well.
Sure, Connie.
My tumor was very My tumor was really small. So I had one of those micro ones that you had shown on your, and when they went in and they removed the tumor, I'm basically cured. I have no more issues with my growth hormone. But because I was diagnosed not till I was 56, I have all the related issues that are with that. So, and my changes over the years wouldn't show in my photos because they were so minute until I hit about 40. So I'm just wondering, that's not the only way to look at it and not realize that, you need blood work out for it. So a comment on that.
When did if you can look back, and when did your symptoms start? Like whether it be diabetes, hypertension, other edema, other comorbidities, that could be when the link is that when your pituitary started. 12 years before that?
No, 12 years old.
Oh, okay. Okay. I mean, my youngest in our practice, he was 15 when he was diagnosed, and he had a surgery at 15, and then he had a second surgery at 18. And my youngest female was 18 when she was diagnosed. Her mom's an RN, and she started noticing changes, so they brought them in. The 15-year-old, when he came to us, his parents are both tall, his grandparents are both tall, all of his younger brothers were all tall, so we've tested all of them to make sure that the others don't have the acromegaly disease. And my oldest right now, my oldest male is 89, and for the women in the audience, I'm not going to say how old my oldest female is, but some of them are in their 80s.
That's a good point to get into the next question, is sort of, are there any clinical studies for elderly acromegaly patients? As we age, our needs physically and mentally changed. This patient says, I get screened, and because I'm not on medications, my bone issues are now the problem. So is there any special protocols or approaches for people 70 and over? Or 60 and over?
Well, I thought they were talking about clinical. There are clinical trials. For some of our trials, they're up to 85 now, because a lot of our acromegaly patients are living much longer. But as far as treatment, we treat them pretty much the same, because they have the same issues, the same common problems, the same IGF-1 level that's raised.
Yeah, I agree. 85 is actually quite standard. As far as if you're on more medications or something, there'll be a list of what you can be on and what you can't be on during the study. So if you, it's determined by your GP or your endocrinologist that it's safe for you to wash out of that medication for the duration of the study, you can also do that. So that's always an option.
Okay, another question that came up is, how often should you really be seeing your endocrinologist? Is there a sort of a magic number in terms of months or years?
In the beginning, when you're first getting diagnosed, you should be seeing them every 3 months, and then every 4 months, then every 6, and then if you're stable, then probably once a year.
Once a year. Okay, because I had someone at our table who said I go once every 2 years after the MRI is done. Like I go every year for blood work, which seems to be a reasonable cadence, but
No, every 2 years is fine too. So we have patients that come from all over the world too. So sometimes they can't get to us yearly. So every 2
Okay.
years, fine. As long as you're being followed, it's, you know, we would like you every year if you can, but if 2 years, we're happy to see you.
yeah. Yeah, I always say, you know, if you have acromegaly, you get the best possible healthcare because they keep watching you, and I think that's true. There was a comment here, a question on that?
Well, no, I was just going to say because I don't live close. I go to U of A and Edmonton, and it's a flight. But so they follow me with my blood work.
Another question that came up was, are there any Canadian guidelines to provide treatment, and are they updated every 1 or 2 years? How does that work? I don't even know that. It's like,
Yes, Dr. Rees, that's on the committee, so yes, they are updated. They were just updated, I think, last year. But yeah, he's always been on the team, and it's a worldwide.
so the guidelines would be sort of the same as you see in the United States?
So yeah, and the endocrine guidelines are what a lot of the doctors come to they meet worldwide. And it's done every 2 to 3 years, depending. If there's a lot of new drugs, then they might do it sooner.
Okay, good.
JD?
Yeah, I wanted to make a comment actually again about the pictures, because when I was diagnosing, my endocrinology team, the surgeon and the neuroendocrinologist looked at the pictures, my picture. And I remember the comment they made. He says, well, how old were you here? I said, well, about 28. And the neuroendocrinologist said, well, if I would have shown this picture to 10 of my interns, 9 would have come back with an acromegaly diagnosis, or at least they would have said, go check it. So photographs are pretty critical because you don't see the features until still have it. Somebody that's trained to see it probably will. So, just a
The problem with photos, especially for some of my female patients, is they don't like how they look, so they don't like to take photos anymore. So that's an issue. So the key to that is I'm like, well, bring me your driver's license for the past 4 years, for the past, you know, as many driver's licenses as you've had. So then you can see the, you know, changes as well in there.
Good.
Or passport.
Great.
They look like you need a holiday.
Yeah. So I want to talk a little bit about sort of how to feel better, quality of life. And Mark, start with you. So what do you do to feel better, or when you have down days, or so do you have sort of developed some routine? You talked a little bit about that this morning, but maybe you can elaborate on what makes you feel better when you have dealing with symptoms.
Well, I have a pretty happy life between my partner and my kids. So there's times when I wake up in the morning and I didn't get enough sleep, or my bones are aching in the morning, and really I just push on, and because I know I have acromegaly, and I know what I do is, and the feelings that I have are 100%, 90% related to the condition I have, and I understand that. So I just push on. I know I have a lot of happy things and joyful things in my life, so I concentrate on those things and just push forward. And I drink excessively.
Except for when he has to come for his blood work. Through our DART program, one of our main tools is the number one thing that we're diagnosing all of our patients is fatigue. And the second thing is depression. So we have automatic referrals that if you check, if your DART score is above a certain percentage, then it's an automatic referral to psychosocial department, or we have a number of dietary departments, whatever, that we need for patients. And then if patients are at Toronto General, because we don't do DART yet at Toronto General, we still have those same options because they are still part of the same endocrine oncology team. We can still refer to those other disciplines, and it's just, we fax it off, they get a phone call, and if you want to go once, that's fine. If you need to go for ongoing support or care, whether it be the dietitian, the psychologist, the sociologist, like whoever, the social worker, it's automatic. We can keep on, you can keep go as many times as you want.
Yeah, I was going to say, what's the DART score?
Distress Assessment Response Tool. The paper one is called ESAS, Edmonton, I can't think of the other, but it's been around for a number of years. We also have, when we were doing the different drug studies, the different quality of life and well-being questionnaires that we had to fill out. Nottingham is one of the questionnaires that we filled out for well-being. And again, if anything that's above 5, you're supposed to automatically refer to another discipline.
Okay, so that's an Ontario thing? I've never seen it in BC.
It's mandated by Cancer Care Ontario.
Okay.
That is what the doctors and the RNs use. Like, I don't think we actually have quote access to that. I might be wrong, but that's kind of what they use to help stay part of how we're doing.
Okay.
So some stuff we just can't get at because it's the government and the doctor's stuff.
And we do a lot of phone calls and certainly a lot of emails back and forth between our administrative assistant, myself, Dr. Izat, and follows, and then everything is printed off. It goes into your chart so that we can all follow along, saying, oh, well, this one wasn't having such a good day. Why? Somebody needs to call them. What was the outcome? Has it been resolved? Do we need to follow up on it in the next visit?
But on another note, sorry, we don't have what is set up here. There used to be 13 nurses in Canada that worked with the endocrinologist. We're down to 2. And that's where the difference is, because the nurses we get to see and talk to and work with before we see the endocrinologist. So with losing all the nurses that worked with the specialist, it's depleted our resources and and better care. Because the government is just pulling back on everything. So it's something that needs to be addressed and fixed, but we're not going to be able to do it because we're up against the government and it's just, they're cutting back, so.
Okay, good. Daphne, we're talking about sort of quality of life, things you can do to improve.
Actually, I love that you guys use these tools. So for studies, we use these questionnaires and depression tools, but for us in the U.S., that's usually in clinical practice, that's for the PCP and the internist to do. So a lot of times we don't know, unless you're actually talking to a patient, if they're depressed. We don't really know unless you know. Most of us know our patients though, so we do know. But I just think that that's great that you can have that kind of tool because then it documents, and then you can put it in the chart, and then you can get a lot of the assistance that you need. So that's awesome that you guys have that in Canada. So as far as quality of life, we do use some of the tools for like the QOL, Acro QOL, and the SF36, which are questionnaires that you do, like 1 or 2 pages that we do in the clinical trials. And I wish it would go to clinical practice, but a lot of times the doctors don't want to do that extra step. So some of the nurses will do that, but then half the time they don't even read it. So we're like, why are we doing these, for the poor patient? But that's where we have to be the ones to advocate for our patients and, say, my patient's just not, the same. What's going on, maybe the levels. So here's one of the things I didn't bring up. So one of the newer things that's happening, and Jill can allude to this before, is when your IGF-1, so you're finally diagnosed and you're treated, and you're now on your medications, and your levels are they're within normal range for your age. However, maybe you're better off at the low end of normal, where you'll feel better, where some people, so say that you're a 45-year-old male and your level is between 90 to 360 is your normal, according to, our labs. So say that you're at 350, but you're still just not feeling that great. So I've been advocating for maybe lowering the dosing so instead of every 4 weeks, maybe getting it every 3 weeks. And I know that's probably off-label, but we do it because all of a sudden the patient's feeling better and like, oh, it's just that 1 week I'm feeling much better, and I'm not starting to get my symptoms back right away. So that's a new thing that's happening, but it's kind of hard to get a lot of the doctors on board because like one time, even for a study, my boss, I'm like, okay, this level is, yes, this patient's normal, but she's still having these same symptoms. She's still having the joint aches, the sweating, everything. Does that seem normal to you? Would you like to have that? So finally, he increased the dose, but I was like, oh my God, I had to like beg him till like almost 3 months later for him. Like every month I would say, okay, this is still not working. Do you not see that the patient's still having sweating and, and joint aches and the headaches and everything? So it's a process that we have to like, because unfortunately some of our docs are, your doc is great. I have an old school doc, so, you have to make it like that's their idea, like, oh, yeah, remember last month you told me you were gonna, increase the dose, but you never did. So it works, it does work.
Jack?
Yeah, so it's the same thing with our clinic. At both doctors, we do off-label prescriptions if necessary. So you'll get a result, but it might be within range, as you stated, but you might still have symptoms. It's about your symptoms. It's about your life. It's about how you feel. So we can definitely adjust. Well, as far as the doctors go, they can adjust as per necessary. It's absolutely, you're right, in my mind.
Okay, Jack, you can hold on to the microphone. The question is for you, how can we be part of the research studies?
Well, I'll give you my card. No, but really, if you want to get into contact with me, we have some stuff coming down the line. But as far as getting into a clinical trial, it can be it's hard to force your way into one or to find one. You can look online. There are online resources like clinicaltrials.gov. If you can search up, you can actually search by condition and do that way. You can also ask your doctor and see if he has anything that is on his mind. But if you're in Western Canada, come speak to me after.
But how many are there? How many studies do they run, like on an annual basis? I cannot imagine there's lots going on.
There's quite a bit going on.
For acromegaly, I mean.
Sorry?
For acromegaly specifically.
Yeah, for acromegaly, there's quite a bit going on. At our site, there's only one right now. Okay,
yeah.
But we are trying to get U.S. companies to do trials in Canada right now. So that'd be nice.
Okay.
Yeah, that'd be excellent. Yeah.
Okay, there was a question about cannabis oil. Does anyone want to comment on the use of cannabis oil?
Actually, I was going to ask about that. So it is approved here. You guys are allowed, right? In Illinois, not yet. But I have patients that buy it off online for their joint aches. But it's 50-50. Sometimes it works and sometimes it doesn't. What do you guys find? Does it help at all? Anyone?
Two kinds of cannabis oil.
The CBD one though, no HCT or HTC.
No, but
CBD oil.
There's
Hemp?
cannabis oil, and then there's the CBD one.
Oh, okay.
Which different.
Do they work differently then?
One, I think CBD is better for anxiety. I think the hemp one's better for aches and joints.
Has anyone actually tried it? Don't worry, no judgment here. Yeah, good. No, I want.
Sleep, but I do need a little bit of the. I do need a little bit of the THC. I do the CBD. The one capsule. I'm doing capsules rather than the oil because I don't like the taste, and I certainly would not smoke it. Anyway, I'd be all night long if I smoked it. Well, with the THC, you get a little high, and then you go to sleep, and then maybe about 3-4 hours, I'm awake again. Yeah, that's on a good night. And usually in the morning, I'm fine because I have no hangover or anything. It's out of my system. I will not do it through the day. In the day, I suffer. I will not take any meds for pain through the day. I'm just too afraid of them. I've got too many things that I have to worry about, and so I need to be able to cope with that. So we do pain. Day pain is ongoing, but once I get going, I can kind of manage it till about 6 o'clock at night, and then everything kind of
gets you, like the legs, the muscles, the nerves, everything starts to seize up. So I am constant motion. And then at nighttime, through the night, with a little help from my friend, and I have tried every pain med, and I do not want to be hooked on oxycodone or anything like that. So I figure this is probably the best way. It's expensive, it's not covered, yeah, but it's my body, so I have to think about what my body can handle. But then at nighttime, when I get up in the morning, like some of you, I can barely walk. And I'm kind of walking on the sides of my feet, trying to get to the bathroom, you know, and then stretching, and as Santonia does, a lot of stretching in the morning and working the muscles and trying to get them working, and then it's another day. On we go.
Okay. JD, you wanted to add something to that?
I have a friend that's a neurologist, and she had shoulder surgery, and she started trying the CBD, just the CBD oil, and she had very good results because she was able to manage that without the opioids and you know, pain meds. So for me, then I tried it. For me, it didn't really, I couldn't tell if it was placebo or not, because one day I started sleeping better, and after, you know, I took it for 2 or 3 days, 2 or 3 drops. I wouldn't recommend that. They say that the smoke is really bad for your lungs. So I don't know if it's placebo or it actually worked. I slept better with it, but I really don't take it. But I know the NIH, the National Institutes for Health in the U.S., is taking a really hard look at it, at cannabis and CBD oil, to see what's going on there. And so I would urge you to kind of keep an eye on that and wait to see what they find, because the problem is that they don't know what the side effects are. Mm-hmm. You know, you just take it, you think you're feeling better, and there's a lot of people that are taking a lot of it. So.
See, I was told, and I didn't miss, so I feel okay tonight, so I'll take it. Or my GP said, every midnight, you take it. Don't get this.
I think a lot has to do with the weather too. I'm kind of in that middle state right now of my journey, where the summertime, spring and summer, you get the warmth, my bones warm up, I feel great. I get into the fall and winter, I'm in constant pain 24/7. And it's just, you know, because of the arthritis and that's coming in that. So like we're all at different levels, but I find that there's different levels as we're on our journey with acromegaly that you're going to hit, right?
Okay. Does anyone know here of any genetic links to acromegaly? I mean, can we pass it on to our children, or does it come from somewhere else in the gene pool?
We have patients involved in both the Irish study and the Italy study for AIP mutations that were linked to the Irish giants and the Italian giants. There's 4 main families in each of the Irish and the Italians that have been linked to it. And when you do these, there's a famous picture on the computer if you type in acromegaly. There's 2 identical twins that are acromegalic, and we go through the different generations. There'll be prolactinomas and Cushing's all in their family, whether it be their aunts, uncles, cousins, whatever, siblings through there. So they have done.
Yeah, so there is evidence that.
Yes,
and
I mean, in our practice, we have a set of identical twins, and I've tested them both. One who is positive, and his sleep study, he stopped breathing 100 times during the study, and his twin was fine, identical twin was fine.
It's interesting.
I do know that I think it is more common than what we know, because I have members in the support group. I have members in the support group that have told me my mom had it. So I think it is something that we need to, well, we can't do it, but I really think that the endocrinologists and the nurses that we have, if we could get some sort of a research study going on in that, I think that there's going to be a wake-up call. that actually, because we'd say, no, it's not, you can't. But, when you got a small support group, and I've got probably about 6 or 7 people that tell me that their mother had it, something's wrong, right?
Yeah. I guess this is one of the areas where we just need more data and more studies done
more
over the
research.
years.
I'm looking at photos of my grandmother in England. I look at them as like an old lady, like she was an old lady, and I can see
In
Yeah.
our practice, particularly in our neck clinic, we have a number of different genetic disorders, von Hippel-Lindau, and other disorder, MEN1s, MEN2s that we've done. We've actually hired a geneticist, and he actually has a 2-year waiting list to get in to see him. But if it's coming from inside the hospital, that list is short. They get speeded up versus somebody coming from outside the hospital, because so many of these different diseases are genetic. Thyroid disease certainly is genetic, and it's carried on the female line.
I have found out 2 years ago that an actual cousin of mine that I've never met, because my dad didn't do the family thing, but a cousin of mine has acromegaly too.
JD, you had a comment?
I mentioned in SMS presentation, it's Dr. Marta Corbinitz at St. Bart's. Send me a note and I will send you all the details. Marta, Korbonits, Corbinitz. I will send you the information. There's an article on Pituitary World News. Just type genetics on the search, and then you'll have all the links to St. Bart's and all of the work that she's doing. It's on precisely on the AIP gene. Very interesting work.
Okay. Okay, there's a question here. How do we get tested for gene AIP? Is that the word? Yeah. Yeah.
So you just, they'll tell you what to do, but you send a
We've actually sent, for certain patients who are of British descent, we have had a couple of them send their AAP and their, I think the other word is called FIPA, FIPA, have sent it off. They had to pay for it because it's not covered by OHIP. It's very expensive. And the same with our Italian, one of our Italian gentlemen who has family history. We've sent his information off, and yes, they did trace it back to both the Irish and the thing, but it is quite expensive, and
So-
OHIP won't pay for it.
So the question then is, how expensive is that? Just curious.
Oh, no, I think it's probably closer to $2,000.
$2,000.
So, yeah, I used to do it with her 10 years ago, and she did them for free back then. But yeah, and it's very expensive. But I wonder if we can get a whole bunch of people to do it. Maybe she'll give us like a discount.
I think they'll ask for a donation, but it's like $100, $150, and they can cover some of it. Don't quote me on it.
We should reach out to her, though.
JD
Maybe I will.
Fascinati said, I can test you for $100.
Yeah, yeah.
Okay.
But that's euros. What currency?
I think it was $150.
Yeah.
It wouldn't be that much different.
No, you just have to ship it to there. We would draw the blood.
We would draw the blood. And
Blood
then
here,
ship it.
and you ship it there.
They
Yeah.
test it.
Yeah, well, I think it's a general trend that there's more and more testing opportunities, and the cost is coming down. So we'll get there somehow.
Because if you do your IGF-1 outside the hospital here in Toronto, it'll cost you $150. If you get it done inside the hospital, it doesn't cost you anything because it's covered by OHIP.
Yeah.
And that's the same in BC. It's the
Yeah.
same across.
It's in Canada. Yeah.
Endo orders it, it's free. The GP orders it, you're paying.
Okay, there's a question over there. Can someone help with them? Yeah, that's you.
Jennifer?
What about just the growth hormone, like in the GP's office? Do they have to pay
A lot of if you don't have OHIP, per tube you're looking at $45 to $55. If you don't have OHIP, so if you're doing it outside, they may or may not charge you. But for a growth hormone level, no, they shouldn't. But you need both the growth hormone and the IGF-1 level.
even the GP just initiate, like if we're talking about how the GPs aren't sort of catching this kind of thing.
Yeah.
Well, if they're not able to do the growth hormone.
Because any outside lab, they want to get paid first. Yeah. Yeah.
Okay, so we've got another 10, 15 minutes. Any other questions? I've gone through all the written questions. Are there... Adam.
I just wanted to add a little bit about the five stages of grief that I can't remember whose presentation it was in, but in my first part of my diagnosis, I kind of did what swept everything under the rug and kept going and pushing through, but I didn't deal with the mental health issue of it because it kind of gets pushed to the wayside, and that's when I had suicidal ideations and stuff and such, and addiction problems. So I really, newly diagnosed people, you got to do your mental health as well. You got to treat it the exact same as you do treat any disease. And the 5 stages of grief, that's what I used through with my psychiatrist and psychologist. And once you hit that acceptance, that's when you can start living normal, I think. I truly believe. Going on to the cannabis thing, yes, I am an avid, I do vaporize it, so, and don't mix up vaporizing with vaporizing the nicotine stuff. If you vaporize flour in a vaporizer, it actually doesn't combust it, so it's not like smoking it. It's not carcinogenic. It's a vapor. So, and there are many products out there that you can use, and it just heats it up, and it doesn't combust the flour, and you can get your THC or your CBD. We're lucky in Canada because it's legal now, and there are lots of stuff coming out. You can get CBD-only flour if you want to go that way, and the oils and sprays are coming out now. October 17th, they'll be starting to come out with more because the edibles will be legal coming. So that's just what I wanted to add. I've had my prescription for 3.5 years. Since it's been legal, I don't have it, and I use it for sleep, my depression that I'm trying to get off of my hard antidepressants and stuff like that, and it helps. I truly believe in cannabis, and I am a police officer, and I advocate for cannabis use. It's not a miracle drug, and it's by all means, and you have to try it to see if it works. But I do oil, I vape, and I believe in it. And I think there's a lot more to come with more research as it's legal, because you can't research it on an illegal thing, like especially in the States. They won't fund any programs for research because it's still illegal federally. But Canada, I think, is going to be coming up with some big things with cannabis, I think.
Thank you, Adam. These are very useful comments, especially on the mental health piece, but also on the cannabis. So,
Thank
thanks.
you.
It's very good.
Very quickly, restless leg syndrome. Is it? I've had restless leg syndrome since I can't remember. Do you ever find this with other patients?
Yeah.
Restless leg syndrome, and now I'm on medication for that. But are you seeing symptoms through other?
What is it? The restless?
Leg syndrome, your legs just do their thing. They don't stop.
Oh, okay.
It's a nighttime thing.
Yeah, you're sound asleep and you don't, it's an automatic nerve thing and there's no way to stop it.
It's very frustrating, and like sit on a plane, I don't sit, I have to take. I would do that for standing up on a plane. Or
Right.
a bus or in a locker.
We've had good success with gabapentin.
Yeah, that's what I take. Yes. No, I take Daphne Adelman,
Okay,
and it's very successful.
yeah.
And like the day I took it, I'm like, why was I not sleeping for the last?
And one of the other things, remember I was talking about vitamin B12 and vitamin D? Also milk at bedtime will help because you're getting your calcium magnesium, because you could be low on calcium or magnesium, and that too could contribute to the restless leg syndrome.
Yeah, no, I just wondered if you saw other acromegaly patients.
And Cushing's.
One more question over there.
If you don't want to take milk, I buy magnesium tablets.
Magnesium tablets.
B1 tablets.
And if you talk to your pharmacist, they'll actually tell you if you take your calcium magnesium tablets at bedtime, it will help you to sleep better. And that's, I just use my glass of milk, but I take my calcium magnesium in the morning to get me to work, but I take the milk at night. But the pharmacist can tell you.
Very good. Any other questions? If there's no more questions, then we're going to ask each of the panel members to give a parting shot, sort of a final comment, a final recommendation. Wrapping up, Mark, do you have anything that you want to leave with the audience before we all take off and carry on with our lives?
Stay connected.
That's a good one.
The acro loneliness is something that I suffered with a long time, and I've been, ever since I've been connected with my acro family, quality of life has improved. Acceptance of my condition has improved, and it's not a lonely feeling. So encourage everyone to stay connected with each other and your local groups. Lots of hugs.
Laurie.
Know your support system, whether it be your surgeons, your nurses, your medical team, the people, the friends and family that are around you. Because we all have stressful days, we all have crazy, idiotic days, we all have emergencies, and then there are days, even in our own group, we get together, exchange gifts, do birthday cakes, and they'll be like, for a lot of our physicians from overseas, I mean, we had one from Spain earlier this year. No one in his medical practice in Spain had ever said happy birthday and given him a birthday cake. He was so excited, and we were taking pictures, and he called his wife and his kids who were staying with him while he was here as an observer and said, look what these guys did. They gave me a birthday cake. And at Christmas time, we get together and we do things together and go out to dinner, and it's like, we need to support each other just like we need to support all of you. And as Mark said, he didn't meet another patient until he was going into different things and drug studies. If you look around our clinics, you'll see there could be 5 to 10 of you every clinic. And we can't get them all in on a pituitary clinic. That's why we've got patients coming Monday to our neck clinic, or patients coming to our thyroid cancer clinic. I had one on Friday afternoon. I had a new patient in the morning for testing, and I had a papillary thyroid cancer patient in the afternoon, and his acromegalic disease wasn't discovered until many, many, many years later. And it was only when he came, our head and neck clinic, we have a surgeon with us, and he said, come and look at this guy, because we've had patients there before, and he said, I think this is an acromegalic. I think you guys need to see him. Yeah, I'll do his surgery for his papillary thyroid cancer, but you guys need to see this. And sure enough, the minute you walk in, you can see the frontal bossing, the big hands, the jaw, everything. And when I spoke to him the other day, I said, how are you feeling? I said, you're on 2 drugs now? And he says, yes. He said, I feel 100% better. And as I said, for years, nobody paid attention. And we all have to be advocates for one another, both for our nurses together as well as our patients and other team members, and just keep it up.
I agree. We have to advocate for ourselves because no one else can. I think you should really just be on. When you go to your doctor's office, for whether you're seeing the nurse or the doctor, don't be afraid to say what you're feeling or how you felt the past 6 weeks or whatever. We can't read your mind. We don't know, like, you've been in pain or you've been suffering. I mean, a lot of times, especially in our clinics, they have 10 minutes with the doctor, not even. So they're afraid to tell the doctor what's going on. I'm like, no, if you don't tell him, he's just going to tell. I'm going to tell him, and then he won't believe me. So, you have to be the one to advocate for yourself, and don't be afraid to, Like recently, I had a patient tell me about her acro rage, and I'm like, for a long time, Deanna, I never knew what that was, and I'm like, oh my God, what is this acro rage? Yeah, but they have, but it's, and then I was trying to explain this to the doctor, and he, my boss is like, I've never heard of that. I'm like, oh my God, nobody's ever told you this before? So you have to be, you have to advocate for yourself, and just, you don't have to, I know you don't need the medical technology, the words, just say what you're feeling and what you're, how your body's feeling, because we can't do that for you. It has to be you guys, okay? And we're not gonna, think of you any differently, as much as, some patients revere their doctors, and I know some doctors are kind of hoity-toity, okay, but there's quite a few. But at the end of the day, they're human. They are human too. They have families. They have and I'm always like the one like, would you like this to happen to your son or something? You have to bring it down to their level again, and don't be afraid to do that, okay? And that's my parting thought.
Yeah, just to add to that, as far as symptoms go, just describe them in as much detail as you possibly can to your doctor. I have a patient who comes in and she brings in a log of how she's been feeling in regards to her carpal tunnel syndrome, which is very nice to see, especially when her medication has been recently adjusted through the trial that we were operating. So that was very good. I mean, the more information we have, the more that we can work with. And especially when it comes to topics like depression, definitely reach out. Just because it's an endocrinologist doesn't mean we can't refer you to someone who can help you. And look forward to a bright future. There's going to be a lot more coming out, as I've stated before. So, yeah, that's everything. Thank you, everyone.
Well, that's a warm applause for the panel. That's a great way to sort of end the discussion. Look forward to a bright future. Continued support, continued education, sharing of information, and Mark, as you said, stay in touch. We're beginning to get to know each other across Canada. We had our first conference 2 years ago. We're going to have another one in 2 years' time, and over time we'll become more and more friendly. We're becoming friends, and we become a family, and help each other along the journey with the support of all the medical people and all the research people to work towards a better future. So on that note, I want to sort of say thank you everybody for coming. I want to thank once more Pfizer, Crinetics, Ipsen, Novartis, Chiasma, and Ionis. We had 6 sponsors, and the Legion in Chilliwack, who's been so helpful in organizing a number of fundraisers that contributed greatly to what we've been doing over the past 3 days. So without them, it would not be possible. So thanks everyone, thanks the sponsors, and safe journey home. Take care.